Hello, everybody. Thank you for joining our AO webinar today. I'm going to give people about 30 seconds to continue getting all their logging on and screens and everything set up before we move on to the actual portion of the talk. But the topic today is the acetabulum, with a particular emphasis on how to manage geriatric acetabular fractures. Now, with the AO webinar series, we're in the hip right now. And 3 weeks ago, we actually had a great journal club going over the details of literature, recent literature, as to what different surgical strategies seem to be optimal, if there are any, for these challenging injuries. So we'll be reviewing a little bit of that, and then moving forward to some actual cases, and then technical aspects of how to take care of these patients. So we're about a minute in, so I think hopefully everybody's got all their tech issues sorted out, and they can follow along with the webinar. Some housekeeping items. We do encourage questions. We will have time for questions throughout portions of the webinar. If you can use the Q&A button to send questions to the faculty and myself, then we will address those in between portions of the discussion. So the Q&A, not the chat, but the Q&A. So we can see your questions, and then we will address them during the case. And I encourage, as questions occur to you while you're hearing our excellent presenters today, please feel free to use that. So my name is Carol Lynn. I am an orthopedic trauma surgeon with an elective practice in primary hip and knee arthroplasty, and I'm based at Cedars-Sinai Medical Center in Los Angeles, California, and I'm the moderator for this webinar this evening. I'd like to introduce some of my colleagues, some excellent surgeons here with a lot of experience. We've got Dr. Richard Yoon, who has quite the nameplate here with multiple titles, particularly in the field of orthopedic trauma as well as adult reconstruction. And just his neighbor is Dr. David Forsch at Mount Sinai, also trauma fellowship trained, but also does hip arthroplasty as well. And so I think we're going to hear some great perspectives from them today and see some great cases, challenging cases, particularly geriatric acetabular fractures. So from the AO, I do have to clarify that AO is an independent nonprofit dedicated to improving the care of patients with musculoskeletal injuries. We do not endorse or promote the use of any particular product or commercial entity. And all of the equipment that is shown here is used for teaching to enhance the learning experience. Again, for our webinar etiquette, I think a lot of us know these rules. Everybody has been muted except for the faculty. Use the QA box. We will review them, and then you can use the chat box as needed. And that between the chat box, I'm sorry, is only for faculty and staff. So for the audience, please use the Q&A box so that we can see your questions and address them. So to get things started, the geriatric acetabular fractures are kind of a unique entity, different from your typical high energy young acetabular fractures. We are hoping to focus with this webinar on the unique aspect of these patients and their injuries and ways that we can improve their outcomes. We're going to be talking about when to operate, whether or not we should be operating, if we're going to fix it, if we're going to replace it, and if we decide to fix or replace, specific technical aspects of how to make sure that that surgery goes well and then the patient recovers as best as we can help them do that. And so we hope that you will be able to recognize the unique characteristics of geriatric acetabular fractures after this webinar and discuss the treatment strategies for optimal outcomes. This is a brief overview of our agenda. And again, this is going to be very case-based, and then hopefully we'll have some time for lively discussion and addressing questions at the end. And then also to highlight our upcoming additional webinars and series that hope to engage all of you on as the year goes by. We will also, our upcoming is 1AO, which is a really wonderful gathering of AO members from all over the different specialties, ranging from spine, maxillofacial, veterinary, and trauma. It'll be held in April. So if you have not already signed up, there's still space. Please engage with us. I think it's a really wonderful conference. So To summarize some of the discussion that was had 3 weeks ago, uh, which was a review of 5 recent articles, specifically looking at geriatric acetabular fractures, fixing versus replacing. Um, what we do seem to know is that while acute total hip in this population can lead to good functional outcomes, it is a technically demanding procedure with a higher readmission risk. The immediate post-op complications do seem to be higher when you combine acute total hip. And when I say acute total hip, that's with or without adjunctive internal fixation. And dislocation is an overriding concern. However, the long-term reoperation risk is substantially lower, and then the functional outcomes are higher if you can get the patient through that immediate perioperative period. But what we don't know is how we can decide who gets surgery, and how do you decide to fix versus replace, and whether or not to stage it, and how to do that procedure. So just to review, I cannot talk about the acetabulum without paying some respect to the masters of the field with Letournel and Judet. This is their seminal book classifying these injuries, which up until then had almost entirely been treated non-operatively, just because we didn't have an understanding of the anatomy or the biomechanics, and they really transformed the field. But even they had recognition that when you've got severe osteopenia, poor bone quality, maybe that's something you should stay away from because the failure rates are high. And later on in this webinar, Dr. Yoon is going to talk about other critical failure red flags for maybe when fixation is not going to be successful. So in general, we should still consider non-operative treatment for a lot of these, provided that the ball is in the socket is round, and it can stay there. But that being said, there are certain situations where you really need to address it with surgery. And so to review some of the functional anatomy, you've got two columns, the anterior and posterior columns, and then the socket is supported in between. Here, that's kind of how I think of it. You've got an articular segment that is supported by two um, structural columns. They're connecting everything back to the SI joint. Um, and the challenge, though, is that a lot of the Letournel and Judet um, case series, and case series probably up until the 2000s, the patient demographics were very different than what we're seeing now, particularly in urban areas. The rate of older patients sustaining these acetabular fractures is increasing and take up a greater proportion of the overall acetabular fracture volume. And most of these, or many of these patients, have poor bone quality. While that is a relative indication for non-operative treatment, they don't do very well when you treat them without surgery. So why is that? Well, most of these older patients are pretty frail, and they don't handle immobilization very well. They don't recover very well, and the longer you immobilize them, the more reserve that they lose physiologically. A lot of these patients have pre-existing diseases. They already have some loss of muscle mass, coordination, loss of independence, or they're at risk. I like to characterize it as many of these patients, even though they seem quite functional and independent, they're running on fumes to begin with. And so they have a injury, and that tips them over the edge. And so we really try to do everything we can to preserve as much function as we can. It's to the point where we have different trauma rules for these patients in terms of what is considered abnormal vital sign in an older patient, and our threshold for considering them to be a trauma activation type patient needing a lot more resources and a lot more evaluation is very different than a patient who is 35 years old. And another unique aspect of these patients is most of the time with an acetabular fracture, you fix it and you want to protect it while the bone is healing. But older patients are not capable of doing that. And that's been well studied in the literature and is a principle of geriatric fracture care, which is immediate or early weight bearing as much as you can. Try to emphasize that mobilization. And the reason for that is because when you have bed rest, you lose a lot of mobility. And these are studies in healthy patients, and they do a lot of this with, studying people who are going to be going into space. What happens if you have prolonged non-weight bearing? You've got patients who are already a little bit iffy on their mobility, and then not only do you lose some functional ability with balance, endurance, strength, but you even have a cognitive decline if you have prolonged bed rest. And we're talking about 10 days, 14 days. And they lose a lot of volition, and then they lose a little bit of that physiologic ability to compensate for increased stress. So you may have a patient like this. This is a classic, trip and fall, minimally displaced acetabular fracture. And I think, I think a lot of people would agree that non-operative treatment for this patient would make a lot of sense. It's minimally displaced, 81 years old, even though he was arthritic to begin with. This is something which meets all the criteria of closed treatment. But in contrast, you've got this other patient, lives alone, walks, does not use a walker, who has a ground level fall and has this classic pattern of an anterior column posterior hemitransverse where the head is subluxating medially into the pelvis. And this is something that is hard to leave alone. And in another unique aspect of these geriatric patients is this extreme catabolic response that they have, which I think is exacerbated by the fact that they're already physiologically at risk. So this is a patient, really nice reduction that my partner did within millimeters, did initially great, but then as soon as she started weight bearing, developed some pain, and you see this absorption medialization. And how do we predict who's going to do that to run the risk, accept the earlier risks of doing a total hip versus how do we know who's going to do well with fixation? Part of that is because geriatric bone already is quite fragile. We have this analogy of a pelvic ring fracture being like a pretzel, and so you can't break a pretzel in only one part. But I would argue that in a geriatric fracture, it's like a soggy pretzel. So you can tear it in one part, and the rest of it is sort of like this paper mache type quality where there's more flexibility because the bone is so much less dense. And then when you put it into a fracture situation, we all know that around 3 to 4 weeks, that's when that fracture resorbs the most dramatically. You get that big inflammatory response, and then you take a sort of paper mache type pelvis and it turns into a soggy, wet newspaper over time. And I think that's where a lot of these failures occur. So not only during that first 3 weeks do you have fracture resorption, you lose your mineralization, you're in this hypermetabolic state, which I think a young person has a lot of extra muscle tissue and bone reserve to withstand that. But older patients, again, they're running on fumes to begin with. So, how to address all of these, how to make these decisions, I think try to, with geriatric patients, you really have to keep in mind that their nutrition is important to counteract some of those catabolic effects, their functional expectations. Most of them want to be as independent as they can, and they need to be immediately weight bearing. But then occasionally, patients, the goals of care are not. Maybe it may not be that. Maybe they're already quite frail. They're living in a home. Um, their quality of life expectation is not great to begin with. And then it involves some detailed discussions with the patients and the families, which I think is a little bit different than what we would see with younger patients. So with that, I'm going to hand it over to Dr. Forsch. And he's going to talk a little bit how to decide when to fix geriatric fractures, acetabular fractures, and then some technical aspects of how to have a successful fixation. And again, I encourage people to use the Q&A during these talks. We will have a little bit of time after Dr. Forsch's talk to address some questions as they come up.
All right. Thanks, Carol. Can you guys hear me? Thumbs up, Rich. Good. So yeah, first of all, thanks to AO North America, Carol, Richard. Certainly always a pleasure to see you guys. Thanks for having me. And I'm going to talk to you about how to deal with some of these geriatric fractures from an internal fixation standpoint. And we'll kind of juxtapose that towards the end with Dr. Yoon's talk about considerations for arthroplasty. I don't have any significant conflicts of interest. I do sit on the education committee for AO North America. As Carol alluded to, so the objectives for my particular portion, one, simply to recognize some of the complexities in common pathoanatomy for some of these elderly acetabular fractures. Sometimes they don't break or behave similar to the younger patients, and they have certain kind of pathognomonic features. So some of that pattern recognition is going to be important to identify. And then considering some of the technical aspects of how to fix these fractures and some of the challenges thereof. This is something I kind of harken back to my fellowship days. I trained with, a second generation disciple of Letournel. And I remember hearing this commonly, just simply not to give up on the osteoporotic acetabular fracture. Similar to what Carol mentioned, we're going to be seeing a lot more of this. Periprosthetic fractures, distal femur fractures. Patients are living longer and they're remaining active. So we're going to be seeing a lot more of this. So it's definitely a relevant and germane topic. So for me, when I see a geriatric acetabular fracture and we're kind of considering some of the options for fixation, some of the questions that I want to consider, kind of like the big four, big five questions. One, is the patient going to have a complication? So, that's going to be my first thing. Am I going to harm this patient by doing something, or is there inherent harm with kind of a benign neglect approach? And is the patient going to die? What's the mortality? And this kind of informs me because we need to make sure that we're having appropriate conversation with patients and families and just kind of level setting to make sure that we all know what to look forward to. And then ultimately, I guess kind of why we're here, one of the reasons why we're here is the patient going to need a hip replacement? So what's that conversion rate if I do decide to fix them? And again, what can I explain to the patient? How does that inform my conversation? And is there a reliable way to predict? Like, is there anything about the pathoanatomy of this injury that can say, hey, you know what? This patient is going to end up in 2 to 5 years with an arthroplasty. So we'll chase those four questions with a couple of clinical vignettes over the next few minutes. And I'd like to present this patient to you from a technical aspect. Certainly, I think we have a lot of fellows on. So, how do you go about fixing these? So this is an 81-year-old patient, and she had a low energy fall from the sofa. And you can see here from the AP pelvis that she has some of the really stereotypical pathognomonic findings of geriatric acetabular fractures. So you can see some of the comminution, you can see the marginal impaction, the supromedialization and loss of offset about the hip socket, and then the displacement of both the iliopectineal and ilioischial lines. So you know that it involves both columns. And so just off of this AP alone, you kind of get a sense as to what the differential diagnosis is with this particular patient. And then looking at the Jude film, so for me, you can just kind of corroborate what you're already thinking insofar as what the diagnosis is when you turn them to the side and get the Judes. And you can see the image on the right with the obturator oblique, the dual disruption of the anterior column. And then with the iliac oblique, you can see the disruption there of the posterior column and some of the marginal impaction. So just based off of that, and then we'll chase that with the CT scan, you can appreciate the fact that this patient has an anterior posterior hemitransverse moiety or fracture pattern. I like showing the full CT scans here because I think it does give you some perspective just kind of coming from cranial to caudal and appreciating what really the pathoanatomy is here. Again, on the coronal slice, you can see the medialization, the disruption of the posterior column, as well as the dual disruption and marginal impaction that involves the anterior column. I like to look at the sagittal as well because it does give me a sense as to what's going on in the posterior aspect of the acetabulum. Certainly, with a lot of these geriatric fracture patterns, the vast majority will involve the anterior elements of the acetabular hemisphere. But it's important to really understand what's going on in the back as well. And you can see here on the 3D rendering and kind of put it all together as to what the displacement is here. And you can kind of appreciate as well the almost sagittal obliquity to the displacement of the posterior column, including some of the quadrilateral plate. All right, so this is kind of what we're dealing with. So you can appreciate from the 2D scan, from the 3D imaging, kind of what we're dealing with here. And from a technical aspect, the first thing you have to do is really get the femoral head out of the acetabulum. And so we'll do that with lateral femoral traction. Oftentimes, these patients will need some modicum of kind of lateralization before you put them into traction. Some centers will put them in traction and just do online traction, but you do need to extract the femoral head from the acetabulum, and there's a lateralization moment that comes with that. The one thing that you don't want to do is just kind of pull traction and have the femoral head engaging on the acetabulum because it's only a short few hours just with simple bed hygiene and turning before they start to kind of wear away and eburnate some of the femoral head. So you really have to disengage the femoral head from underneath the acetabulum and extract it from the socket or from the pelvis. And this is what that looks like intraoperatively, just with a femoral distraction pin placed into the femoral head. And so this is my first technical maneuver when I'm doing this. This is all done from an anterior approach through an AIP stoppa approach. And once you lateralize the femoral head, you can pretty much see how well you can just affect the buttress and containment effect. And so that's the first critical point when you're dealing with the anterior acetabulum. It needs to be contained. The femoral head in a lot of these geriatric fractures will anterosuperiorize and they'll follow the anterior column. So you really have to close that down. And you can get a sense of that. I'll utilize a ball spike pusher with two discs, and I will just simply push on the anterior column. I'll push on the quadrilateral surface and posterior column, and then that just kind of gives me a sense as to how the pelvis or how the femoral head is going to be contained. And you can appreciate that here with restoration of both the iliopectineal and the ilioischial lines. And then there are a variety of plates that are on the market that you can use that will allow you to buttress both the anterior column and the quadrilateral surface. And once you do that, you want to make sure that you're mindful of any marginal impaction. So you have to localize and you have to graft that articular depression. And you can see that depicted here with the freer elevator that's localizing where that area of marginal impaction is. And that's important to note again from your preoperative templating and understanding. So you can't just contain the acetabulum, you also have to try and make it congruent and you have to maintain that. And so there are kind of two ways that we can do that. You either can reduce the columns and buttress it, and then you can localize that and tamp down through, say, a cortical window, which can be a little bit challenging because it's more of a radiographic reduction. You kind of have to find and localize, and then you have to tamp that down, and then you find a way to, raft it or fix it. Or you can work through the fracture. It's almost like a saloon door that just opens up. And before you bring the columns back together, you can either use a tamp or I use an osteotome as depicted here, just to tamp that area down, graft it, and then you can raft it with a subchondral screw. And from a technical standpoint, I'm a big proponent of really getting screws close to the articular surface with these geriatric acetabular fractures, because you either hit a home run and you kind of get it, you graft it, and you hold it there, or it's a bit of a swing and a miss, in the sense that if they do displace, then now you have the femoral head that's abutting a screw, at which point, they can lose their joint quick, fast, and in a hurry. But if they do subside and you have that raft that's appropriately placed, then they can tolerate some incongruity for some time. So I really try and localize that as best I can, and really get those screws subchondral and juxta-articular. The next step is really just kind of locking that door down and securing that anterior and posterior column. So this is a screw that I almost use with every acetabular fracture that I do, that drop down screw that's going juxta-articular adjacent to the cotyloid fossa and down into the posterior column. That's a very long screw that you can use that has a very, very robust bite, and it really sucks down and buttresses the anterior column quite well. And so the final construct ends up looking something like this, with a congruent contained joint with very robust fixation. And this is what it looks like. So just from a technical standpoint, I just wanted to put that out there because this is a very, very common fracture pattern that you'll see, that really has a lot of the pathoanatomical elements that you'll see with some of these. So we'll look at another one that is a little different, but similar features. This is an 89-year-old lady who's quite active. This patient could probably beat me in a foot race at this point. And you can see similar components. She does have some anterosuperialization of her femoral head within to the pelvis. You can see the disruption of both the iliopectineal and the ilioischial lines. Similar anteriorly based moiety that we just showed in case number one. But again, you can appreciate her osteoporosity just looking at her CT scan here coming down. So similar fracture pattern, and we'll employ some of the same features from a technical standpoint that we just talked about in case number one. And so looking at the surface rendering 3D, you can see a retroacetabular extension, some blowout there of the quadrilateral plate, but a little bit caudal to the brim. And this is what we're dealing with, right? So same type pattern, just a different variant. A lot of these will have different transitional patterns, we'll say, and not every disruption or violation of the quadrilateral plate extending into the posterior column is going to be different, but same methods: lateralization, getting the femoral head extracted from the pelvis, the buttress. And you'll note here that there's really just one ball spike pusher with the disc, and it's pushing from anterior. All right. And that's important because, again, like I just noted, not every quadrilateral blowout or comminution needs to have that buttress. And if it's caudal to the brim and it doesn't extend up to the brim, then the femoral head can't medialize. So in her particular case, we still decided to buttress it, but understanding just what her pathoanatomy is, she just really needed that containment and that buttress down and the restoration of the anterior column here with the same drop down screw. And then you'll note here what her fixation is. Same graft and localization and grafting of the articular depression. And then this is what her final construct looked like. And after just a fortnight of follow-up, this is where she was, right? And so you guys will see this. And for those of you who have done some of these, that you can appreciate that there's a fair amount of emotional leakage, I say, when you see these patients in follow-up and you see them start to pull off their fixation. And it's important to note, so I had a bit of a blunder here with this case, and I like to say, I'll tell the residents to mind the anterior ring. Um, you know, One, the anterior pelvic ring in general will get pretty osteoporotic as we age, and they may have little parasymphyseal fractures that can be unrecognized. And if you're looking to do fixation there, what I ended up doing here was putting a screw right through an adjacent that parasymphyseal fracture. So, you kind of go back and it's like, oh my gosh, what was I thinking? But she pulled off, and then so we start following her pretty closely, and I'm afraid that she's going to pull all of her fixation apart. And this was her at 5 months. And this lady is really a go-getter. She was having no pain and, no grass grows beneath her feet. This lady really gets after it. And we got her out to 5 years, which is pretty extraordinary for trauma follow-up, especially for some of these octa and nonagenarians. But she maintained her fixation. And I'd like to think it was because of that drop-down screw that really kind of saved us going into the posterior column there, juxta-articular. But she did pretty well, even despite having some radiographic degeneration, and she didn't displace any further. And this was actually her. I just saw her, I think, this past week or so. We still keep in touch, and she's back to her full independence, ambulating without any assistance, and without any pain, and really good functional outcome score. So that was definitely a win. But it brings up the point that is really, really relevant that Carol mentioned in the introduction with some of these acetabular fractures in geriatric patients is the relative osteopenia, osteoporosity. And so this was actually a really nice workup that was done from our colleagues out in Atlanta and Emory and out in Seattle, whereby they did CT scans to quantify the degree of osteoporosity in the anterior ring and see where the most dense bone was. And so the most dense area in the anterior ring, what they found was in the anterior and posterior aspects of the superior pubic ramus, as well as along the inferior aspect of the cotyloid fossa, right where that drop down screw goes that I showed you. The least dense area is going to be in the inferior ramus and along the posterior pubic body. And it was just a nice study, I think, that was done that just kind of highlights that when you're considering osseous corridors of fixation in the geriatric population, to really try and aim for and optimize the most robust fixation. And so that said, these are just some of the recent cases that I've done and kind of some of my anterior ring fixation. So I like to get really long screws. I'll go transsymphyseal, kind of PRN as I need to really just drop as long a screw as I can, and engage all of those areas of really good dense bone in the anterior ring. And sometimes you can even get a bit of an interference fit with some of your fixation constructs to really fortify that anterior ring. So again, mind the anterior ring. They get osteoporotic. You don't want them to lose fixation. So those are kind of some of the elements of the anterior moieties, and we'll finish up just considering some of the posterior elements with this 66-year-old guy, another very, very active individual. He fell from a scooter. This guy works for a filming company in New York. He's like a cameraman, runs and films all the action scenes. And he had this injury, which is pretty significant. Again, you can see the disruption of the ilioischial line, his posterior wall, and so he's dislocated. So really no tricks or anything there. He has a fracture dislocation of the posterior acetabulum. And what's noteworthy, if you look at his CT scan, is that he has some degree of embarrassment to the femoral head. So he has some flattening of his femoral head from his injury. You kind of can appreciate some of that right about here. So, what we know from some of the literature in regards to the posterior fractures, or, the folks that seem to do poorly, or individuals who are older, right? They have a femoral head lesion, they have a multifragmentary, marginally impacted posterior wall or posterior moiety fracture. So this guy has a lot of those harbingers for poor prognosis. And again, talking about how you inform your patient. So we had a long conversation with this guy about, the risks of fixing it, and some of the challenges potentially with arthroplasty. And this guy was super, super adamant to fix and maintain his hip, despite understanding all of the risk and whatnot. So we decided to fix him, and we clamped his posterior column. We put fixation through his ramus retrograde through the ischiotuber and out, and with restoration of his column and maintenance of his congruity, which is going to be really paramount. And Dr. Yoon will talk to you guys about that as it pertains to arthroplasty. But we were able to restore his column, restore congruent hip socket, and then we simply put a strap plate over his posterior wall after fixing his column. And then this is what he had. And so we contained him. We got him as congruent as he allowed us to be. And whenever I, do this particular construct, I'll utilize an intraoperative spin just to make sure that everything is as righteous as I think it looks. And then so this is how he left the operating theater. So just a technical point again to the fellows, and a shout out to my buddy Miguel, who was a co-author in this study. For those of you who haven't utilized this screw, when I'm teaching the residents, there's oftentimes some trepidation when we do it in the lab. But this is a very safe screw, placing it into the posterior column from the tuber. And it's pretty far away, about over 5 centimeters from the sciatic nerve. And at most, you'll get a patient that may have some tingling in the gluteal fold. But I would invite you guys to familiarize yourself with the anatomy of putting in this screw. And thanks to Miguel for his work on that one and kind of showing the community that. So the patient we got out pretty far. He's at 4 months. This was him, and he was maintaining his congruity. Everything looked pretty righteous. And at about a year of follow-up, he was back to work and surprisingly felt great. He didn't have any pain, and said that he felt like he did the day before he broke his acetabulum. So sometimes they'll surprise you. And this was his gait. He had something going on with his left elbow, but he was already pretty stiff. But despite, the subtle gait disturbance that you see there, he was very mobile, had good functional outcome scores, and looked to be doing very well. So back to the big, questions that I ask. So what do I want to know? So is the patient going to have a complication? And there's, not a whole lot of literature out here, but there's enough that kind of helps inform us. And this, I referenced one of the papers that came out a couple of years ago from the European Journal of Orthopedic Surgery, where they collated a lot of different papers that included over 3,900 patients. And what they noted was when you're looking at fixation versus arthroplasty, the rate of complication, non-fatal complications, was about 39% in comparison to the 20% for arthroplasty. A little ill-defined, but it was mostly in regards to the rates of DVT and thromboembolic events with fixation. And then as far as infection, there was a lower rate for the internal fixation in comparison to the arthroplasty. Is the patient going to die? That's kind of a wash. So the mortality rates are pretty much the same, just upwards of 20% when you collate all of the studies, but it can range upwards of 30% depending on what you read. And is the patient going to need a conversion to a hip replacement? And again, collated, all comers, pooled is about 15%. And again, in some of the other studies previously, that has been upwards of 30%. And then is there a reliable way to predict? We like to kind of hang our hat on some of the radiographic prognosticators and say, hey, this is going to portend a poor prognosis. And maybe not as much as we think. And so a paper that I reference a fair amount that helps me inform this is one that came out of Maryland from the guys at Shock Trauma. And they had a pretty well-designed study with a lot of patients, relatively speaking, and their rate at about 4 years was about 28% of conversion to arthroplasty. But what was noteworthy was that there was no statistical significance between the patients who did and did not require arthroplasty. So it makes you think, wow, is that gull wing sign and that marginal impaction that we all learn about, is that really prognostic for patients needing a conversion? What was also noteworthy out of their cohort was that there was about a 2 times failure rate for the patients that had any involvement of the posterior aspect of the acetabulum. So posterior wall fracture dislocations, transverse posterior walls, posterior column, posterior walls. It was something about having that posterior wall moiety that did not portend well for patients. Although it wasn't significant, it certainly did have a significant trend in comparison to the other radiographic parameters. So some of the take-home messages is certainly complex. I do not tout that I have this figured out. I've been doing this for, a fairly long time, and I do a fair amount of it for sure, and I still haven't figured it out. So it's definitely complex and individualized. The goals of internal fixation: one, you need to contain the acetabulum and you need to make it congruent. The anterior aspect of the acetabulum does not do well with the lack of containment. The posterior aspect of the acetabulum does not do well with lack of congruence. Mind the front, especially in these elderly folks. You need to optimize your anterior fixation. Long screws, understanding your trajectory and screw corridors, or osseous fixation corridors, and really try and get as long a screw as you can. And then don't be nihilistic about osteosynthesis. I think sometimes the tendency is to just say that, we're going to do arthroplasty on everybody, and we're training a lot of people to do arthroplasty, between trauma fellowship, joints fellowship, hip preservation fellowship, sports fellowships. There are a lot of folks coming out who think they can do an arthroplasty pretty well. But I would say that there is certainly a role for continued internal fixation consideration in these patients. And with that, thank you so much. I'll stop my share and turn it over to you, Dr. Yoon.
All right. Yeah, I don't see any questions in the chat as of now. I do have some of my own for you that I think we can bring up in the discussion later. So take it away, Rich. Oh, wait, we do have one question here. Is there any role for unicortical mini frag in the quadrilateral plate?
Unicortical mini frag. Um, you need to buttress it. You can use any kind of plate that you want. You want to try and get bicortical screws where possible. Most of the time, when you're talking about infrapectineal buttressing, you can get a bicortical bomb in the sciatic buttress. And so you could do that with a mini frag. I don't generally do that. Some folks will use a small fragment plate. I think a mini fragment plate is probably a little bit too small. The more commonly used place for me when I'm dealing with geriatric acetabular fractures is if I have a juxtaarticular low anterior column. You can't really get good fixation in the area around the joint. So you can try and use a mini fragment plate that's unicortical locking just to kind of augment and fortify some of your main buttress fixation. But I don't generally use a lot of mini fragment unicortical fixation in the pelvis and acetabular fractures for older people.
And I think
Yeah.
sorry, go ahead, Rich.
No, I was just, and for the person who asked the question, just remember, you have to think about your instrumentation. When you're in the front and you go into the quadrilateral surface, it's a deep hole, and that there's a reason why we have pelvic instruments and screwdrivers and drill bits that are long. I am not aware of any mini fragment system right now that can facilitate that in a safe manner. I mean, putting a 2.7 screw sometimes in that thing can be a little bit. We have captures and stuff for 3.5, so always think about your hardware and how you put it in also, because that's going to be a little bit difficult.
One question I have for you, Dr. Forsch, is do you ever consider, or what is the role of percutaneous only
Yeah,
fixation?
great question. I don't do it a lot, but certainly if someone is kind of a less is more, they're not very displaced or non-displaced, low functional demand, then you can do that kind of prophylactically. The problem that I have with that is, or the challenge I have with that is that most of these need a buttress. Percutaneous fixation is great in young patients, right? Because they have the osseous corridor to hold on to a screw. Elderly people don't have that. That's truly a hot dog in a hallway. And there are other, there are newer forms and iterations of fixation that try and address that. Jury is definitely still way out on that stuff. But I will utilize that, I would say, only a few times a year when I'm just trying to stabilize something. In full disclosure, I've had a couple catastrophically fail.
Yeah, I think we have a follow-up question from the audience around the same. How do you decide between percutaneous only and accepting maybe not a perfect reduction because you can't push out completely? And that is, again, we don't have an answer to that. I do know that in conversation with people at my own institution, it's, again, the goal here is you got to get the patient to mobilize and feel confident that they'll be able to stand on that and the hip won't dislocate into the pelvis. So I think, cases that are less displaced or patients who are exceedingly ill or fragile but have a displaced injury and can't mobilize out of bed at all, then I think percutaneous fixation has a role there, where maybe in a perfect world you would do non-operative with 4 weeks of traction and but you just can't do that in these older patients, and you don't want to be doing 800 cc's of blood loss in a 2 to 4 hour open surgery.
Yeah.
All right, so we'll have some chances for more discussion in a minute. I don't want to shortchange Dr. Yoon's presentation, which also has some great cases and some great discussion. So take it away.
Thanks, Carol. Thanks, Steve. That was a great talk. And thank you to the AO for having me on. So my role is going to be talking about fix and replace. And when it comes to this, I think it's important to know a lot of things that Dr. Forge talked about. This is really it's not an algorithm. Just like he hasn't figured it out, I certainly haven't figured it out. And it's really individualized to each patient. So starting with the case here, kind of something similar to what you saw in Dr. Porsche's in talk. 71-year-old female, fall down 2 steps. You can see the osteoporosis that's here. It's medialized. She's pretty healthy. She travels a lot with her husband, still works as a receptionist, a community ambulator without any assistive devices, without any previous hip or pain issues. And for this person, it's something you can always debate. You fix this alone and fix and replace. And at least for the 3 faculty members here, we do both. And this is where I think it gets even a little bit more difficult to decide if you're going to take on the extra risk to put a joint in. I just want to go over our treatment objectives when it comes to elderly folks, especially when it comes to lower extremity fractures. We can't harp enough that our goal is to minimize M&M, but achieve a stable, reliable construct in the lower extremity in order to allow for early range of motion, weight bearing, and mobility. This is really important for all the stuff that Dr. Lin said earlier about kind of avoiding that sarcopenic decline and getting grandma and grandpa up and walking as much as we can. Geriatric acetabular fractures are no different than hip fractures. 1-year mortality, 30-day mortality, all ranges in the same kind of high range there, just like our periprosthetic fractures as well. And again, like I said, we want to avoid another future operation. If you've been doing this as long as we have and you've been in the same job for a long time, these patients tend to come back when you don't want them to. And for me, this is one of the things I think about, just like Dr. Porsche alluded to, when it comes to whether or not I'm going to put a socket and a stem on the other side. So really, the question is who gets fixed and who gets fixed and replaced, or some variation of this. And we really want to look at the outcomes of ORIF alone in the elderly. And again, when you look at these papers, a lot of the times you have to take into consideration that a lot of the authors here, which are our friends, sometimes they only wear one hat. And we were kind of discussing this before the webinar started, that sometimes it's just hard to coordinate with our joints colleagues if you don't do it. So take that to kind of in account whenever you read any of these publications. This paper here, midterm results, injury 2013, 59 patients, non-anatomical reduction was 29%. Patients had dome impaction and a gull wing sign. And the odds ratio was about almost a 24-fold risk of conversion to THA within 2 years. Another study out of Shock, 61 patients almost 10 years ago, comparing ORIF versus non-op and PERC. 28% were converted to total hips within 2.5 years. Out of the Harvard group, before Mark went west side, looking at 37 versus 37 patients, there was a higher reoperation rate in the ORIF group with worse Harris hip scores in that cohort. And again, that 21% conversion rate within 2 years as well. On the joints aspect side, from Canada, looking at the National Canadian Database, a total of 1,725 patients, younger and older than 60. This was the breakdown that was there. And overall, in the older population, there was almost a 20% conversion rate to THA when we're talking about after fixation of the acetabulum. Again, Arvind and Mike Weaver from Harvard looking at kind of a systematic review in patients over 55 years old. 38 patients, almost 4,000 patients. Pool conversion to THA risk was 15%. So really the question kind of comes up is, how do we avoid this conversion? Because a lot of these patients in general, they're getting older, they're on blood thinners, they're getting sicker. You kind of want to avoid that second surgery if you can, because it is more complex than a primary total hip. And I think we already kind of know the answer to this question. If you haven't read this paper, this is a classic article by Dana Mears out of Albany. He's kind of the godfather, the OG of acute acetabular fracture. when it came to acute total hip for displaced acetabular fractures, and he published kind of this long-term longitudinal study over 20 years ago. So you have to go into your archives for this. And really, the defining outcome for this is if you have an acute fracture and it has a poor prognosis, irrespective of the initial treatment, you should really think about putting a total hip in. This is something that I think was really ahead of its time. I know that for the traumatologists around that time, really it was one of these things that, I'm pretty sure Dr. Mears got eggs thrown at him at certain meetings when he brought this up, just because, you know, sometimes if you only wear one hat, you don't think outside the box, and you have to think about what the best outcome is for our patients. So, what are the poor prognostic factors? Another paper that is a classic paper. If you haven't read this, it's an easy, short read. Jeff Anglin looked at 48 patients and 34 with pretty much follow up. And this gull wing sign, this classic superior medial dome impaction, and honestly, a lot of times it doesn't look as pretty as this. Sometimes there's comminution that comes with this. It is absolutely predictive of failure, and it's not even a question where the consistency of the gull wing side and the Marshall impaction have shown early arthritis as well. And when it comes to looking at how the fix and replace patients do when you have acute arthroplasty, the outcomes are pretty consistent. It doesn't matter which paper you look at over time, the outcomes are pretty similar. Early weight bearing is allowed, and there's variations of that in terms of foot flat weight bearing and heel slide versus early weight bearing as early as 4 to 6 weeks. The patient reported outcome scores tend to be better than ORAF. The outcome scores are definitely better than delayed total hip, whether it's wait till they heal in 3 months and come back when they're really sarcopenic and not doing well, or if they fail and they're post-arthritic later. Lower complication rates, with the caveat, obviously, that you have to worry about dislocation, and obviously a lower reoperation rate when it comes to a later conversion or infection as well. Any other potential benefits? This is something that we looked at our center. And mind you, the thing here is that we kind of pre-select for this because we do both. When we have an area where we have marginal impaction or somewhere where we're kind of worried about it, we self-select, and we have no hesitation in terms of doing a fix and replace. All the patients in this were made at least foot flat weight bearing is tolerated. And if you don't know what that means, we don't ask our patients to toe touch a lot of the time. At least for my patients, what I ask them to do is keep their foot on the floor with a walker and just slide their foot. It kind of keeps the joint reactive forces around the hip a little bit less than if they were like non or toe touch weight bearing, but also gives them stability for balance. Not surprisingly, because we self-select, it didn't translate into a lower length of stay at home dispo. If you look at our overall rates, it's about less than 7 days for both populations. Almost 50% rate going home in the fix and replace versus 40%. But you compare that to the ORF literature alone, the numbers in the ORF literature are significantly higher. I think this is a kind of a bias that we have at our center because we self-select who we're going to fix and who we're going to fix and replace. And again, these patients were all, like 90% of them were all done in the same surgical anesthetic setting. These were all done in a front-back kind of scenario, unless it was the all posterior fixation. And nowadays I kind of do a front kind of scenario where I'll go anterior for my total hips as well. So how did our patient do? Going back to our case, again, just as a reminder, very active 71-year-old, pretty healthy with no previous issues. And for her, looking at the CAT scan, again, if you look very carefully, the marginal impaction isn't as clean as the gull sign. There is comminution, and certainly I'm not as good or slick as Dr. Forsch when it comes to getting this down and getting that rafter screw in. For me, it's a faster, more efficient case when I can get this done. AIP stopper approach. This is an old school 7-plate, kind of getting that joint as okay, not exactly that perfect. And then when I go to the back, fixing her from the back and then putting the cup in. Some tips and tricks here. Whether you're flipping to the back and putting a posterior column or doing everything from the front. I think if I had to do this now, this is an older case when I first came out of practice, I probably would do everything from the inside and the front and then kind of extend my into a DA hip kind of approach and do it from the front. When you're putting the socket in here, a couple of tricks: under ream your socket by two. Even when our joints colleagues kind of try and do an acetabular fraction, it's an acute discontinuity if you think of it in that way. Pelvic discontinuities in the chronic revision total hip scenario are old. They're sticky. There's scar tissue. There's fibrinous tissue. Here, everything's mobile and it's moving. So when you have this buttress under ream by two, use a revision socket. Get that nice press fit, and then drop screws up into the supraacetabular region to get better bite. Depending on which company that you use, if they're a line-to-line ream or under one ream, this rule of thumb by under ream by two typically helps. Sometimes if it's a little tight and you can't get the socket fully seated, you might have to deepen it a little bit. But even then, at the very least, it's under ream by one and never really a line-to-line ream. She went home on post update 4. She was weight bearing and tolerated posterior hip precautions. She was a rock star. She did well. 6 weeks, she's barely using a cane for balance here. And then in 4 months, she went back to work. This is her at 1 year doing well. And the last time I saw her, 4 years out. She hasn't come back after that. She's actually gotten her distal humerus fixed by my other partner, things like that. And she's otherwise doing well, but no subsidence. The plate and everything looks kind of solid, and the hip obviously looks pretty good too. What about our subacute delayed presentation? This is a 74-year-old male. He showed up to my office about 8 weeks out. Around that time, he fell, gone to an urgent care. He was sent home with negative knee X-rays, which was a little bit weird. They placed him on naproxen. He was probably eating those pills excessively. He actually went to the ER, got admitted to the ICU with a GI bleed, got diagnosed with new onset AFib, CHF exacerbation of bilateral lower extremity cellulitis. Ortho was never called. He was treated for everything, stabilized, and sent to a subacute. That's when he showed up to my office. And he was short and in pain. Instead of getting another knee x-ray, we got a pelvis, and this is where he sat. This is something that obviously 8 weeks out is something that we need to take care of. And classically, all the stuff was true. He was 8 weeks out. He was wheelchair bound. He was miserable. He had a stage 1 D cube on his sacrum. His wife was worried, and this is something that we admitted immediately back to the hospital. Called our cardiologist for optimization, and planned to do the surgery a couple of days later after his CHF had actually calmed down. You can see here on the Judays as well. This is an up and out deformity, and when you look at the CAT scan, and again, I just like Dr. Forrest, you want to really look at the symmetry and everything that comes top down. One of the things you'll note here is that his femoral head is essentially gone, along with this posterior wall. This guy has a big problem in terms of reconstruction, and for this scenario, even as short time as 8 weeks out, this is something that wasn't going to do well. So essentially, this is a Pipkin 4 with posterior wall loss. What do we do now? And again, the goals are the same. Reconstruct to allow immediate weight bearing. His problems are he has a non-viable femoral head, a non-existent femoral head, and a non-existent posterior wall that goes into the column. So my solution for this is going to be a standard Coker-Langenbeck posterior approach. I do a standard neck cut to get the head out of the way. I'm going to recreate the posterior wall using the rebar technique, which I'll show you, and then using a revision cup and kind of backing up his abductors and his stability using a dual mobility articulation. So the rebar technique is very, very simple. Ream up and template. You can leave the reamer in there as you're templating for it. Plate over the reamer and fix it to kind of modify and kind of estimate where your posterior column is going to be. You can place your cup and your revision screws at this junction. And here it really shows you where the void of the posterior column is going to be. You put your rebar in where you expect with your 3-5 screws, kind of sitting proud. I supplement that with an extra plate, and then you cement that in with bone cement in order to recreate and kind of give extra stability to the socket in the acute period where the other less than 50% of the cup is getting osseously integrated. This offers you a nice buttress and everything to make sure that your cup doesn't have acute failure either. So closer look here of those screw heads being covered, both plates being covered, and then like kind of that strap plate giving additional fixation to that porous surface in the back. This really gives it a robust kind of solid socket while the other half of the cup kind of heals into the pelvis. This is him kind of the Jude views. You can see where those screws are sitting sitting a little bit proud of where those plates sit. Leg lengths here look pretty good. He's doing well for balance and using only a cane. And 1 year follow up, no cane, doing well. Back to traveling with his wife, and really no complaints. A little bit of HO formation here, but no functional deficits and no kind of bridging callus there. So take home points again, like everything we do in the geriatric population, our goals are to have something to come out of the OR that allows them to mobilize early, weight bear early, and minimize any morbidity and mortality. Critical analysis through radiographs and CT scans. And honestly, sometimes it's a critical assessment of what your kind of limitations might be. Goal sign, marginal impaction. For me, it's faster not to consider that, do a faster case and put a socket in when I need to. Femoral head impaction or AVN or severe comminution are all kind of poor prognostic indicators. And for me, is a very quick trigger to go to an acute arthroplasty with fixation. Technical goals are to recreate and restore the columns for a stable base. Some of our joints colleagues, when they are presented with an acetabular fracture and asked to help, they're only thinking with only the socket in mind. I think as a traumaplasty surgeon, you have to think about how you're going to give yourself support for your socket, and then really kind of have that support be help minimize the complications that can occur with that acute arthroplasty. A really good tip is to under ream by 2, no matter what the company is. Use a revision cup so you can get multiple points of fixation up into that supraacetabular region. Weight bearing is tolerated with hip precautions. And like I said, foot weight bearing with the heel slide is okay too to maintain that balance. And your target really is to get that lower length stay. And every administrator always will be happy when you're sending them not to a subacute rehab and getting them home at a higher percentage. Thank you very much, and looking forward to the next session and the Q&A.
So one of the questions we have earlier was, what are your thoughts on using the distraction approach that as you mentioned, joints colleagues usually, if they see a pelvic discontinuity like a 2-column injury, the first thought is cage, like a distraction cage or some reconstruction ring. What are your thoughts on that?
I mean, so it's funny because, I did a webinar with a couple international colleagues for FOT last summer, I think. And, outside of the US, they're not like subspecialized in a specialty. They go by body part, right? And they were really big proponents of an acute cage. I think that for two things. Number one, the distraction technique for a socket in a chronic discontinuity that Proposky described is entirely dependent on that fibrinous tissue, right? You need to distract it, and you need the bounce back tension for that for the bone to really collapse back into the socket. So that's something that I feel like doesn't really apply in the acute scenario. And when it comes to a cage, the thing that worries me the most, despite the literature saying that it's a good option, is just the fear of infection. These things that have a higher level and higher risk of infection, and it's going to come back to me anyway. And when a cage gets infected, that is like one of the worst days of my life, right? And all you have to do is deal with one, and you never want to deal with that again, because you really can't take it out. You're going to end up chronically suppressing them. And if you do have to take it out and they got nothing in there, that means that they're bedbound, right? You can get creative with articulating spacers, but it's just an absolute nightmare.
And I think,
sorry.
Go ahead.
No, I was going to say that's a great point. I mean, arthroplasty acutely like that is kind of a one-way ticket. If it goes south, it goes south hard.
Yeah, you went straight to the end game, kind of.
Yeah.
Another question we got is kind of again along the socket. Any tips on getting the anaversion and getting the cup to stick on its own?
Yeah, so
there's a trade-off between getting good bony support but getting in the right version.
So two things. I'll for my primary practice, I do a lot of DAs. Actually, we published a kind of a technical trick in arthroplasty today last year. And as traumatologists, we're very comfortable doing this. If you ask our joints colleague to identify the axial handle on a fluoro, they have no idea what's going on. So even if you have the 20-year-old GEs, if you unlock the axial handle on the back of the dial, right, there's 0 and a 30. If you tilt it back and you go in between the middle hash mark and 30, you're at about 20 to 22.5. So one of the reasons why I like doing it from the front now is I'll set my socket and I'll have it flush on that 22-degree angle, and then I know my anteversion angle is going to be pretty solid. Now, if you're a posterior person and you want to do it from the back, what I would recommend is if you're in the lateral position, get on a pegboard, the down leg as much as you can, keep it straight as possible. Don't flex it up. And with the pegboard, if you bring the C arm in the opposite way, so if you have the base towards the butt and you push it all the way in, you have a pretty good shot of where your socket's going to go in. So obviously we have all the stuff that we taught as residents, look at the TAL, look at everything like that. But a lot of times in the acute scenario, your internal landmarks might be off. So that's what I'm going to rely on fluoro, kind of use a pegboard and the fluoro technique backwards so that I can, again, at least estimate the anteversion with my socket going on the fluoro in the lateral position, if that makes sense.
Yeah, and I think, Ted Manson out of Shock actually did a great technique paper, and it's about getting cups in and different approaches, and it's got nice images. It is hard to, especially in these large posterior wall cases, not like the case that Rich showed where the wall was gone. Most of the time, if you're dealing with it acutely, you've still got wall there. And it's interesting that the cup fixation does not really depend on the posterior wall itself. What you need is you're trying to wedge the cup in between the ischial pedestal and the bone behind the AIIS. Those are your two anterior column supports for the joint. And if those are reconstructed and stable, and you have a multi-hole cup, you can usually get the cup, and you're not trying to medialize, I think, a ton. That's the key here. You're not trying to really medialize, which is a bit backwards from our typical, elective joint approach. You actually want to keep the cup relatively lateral right at that edge and expand and push against those two pedestals. And then you can at least get the cup to, you're sort of seesawing on that axis. And then if you've got a good multi-hole cup, and a lot of the new designs now have very good porous coatings and a lot of good hole options. If you can get some screws nicely up into those the gluteal pillars or those buttresses, the group out of San Francisco recently did a very nice posterior column bone fracture density map of where that bone is, and ideally one into the ischium or one into the anterior column or even the quadrilateral plate. Then you've basically got the wedge fit and you've got the screws to prevent the toggle. And then if you want to, you can still plate the posterior wall, or you can use these really innovative, nice sort of oncology-inspired techniques that Dr. Yoon just sort of showed. I think, unfortunately, we are out of time, but it looks like we were able to get everybody's questions addressed. And so what I'm going to do is then sort of bring it home again and try to summarize a lot of the really excellent points that everybody made today. So again, these geriatric patients are unique in terms of the considerations you have to discuss. There's a lot of preoperative expectations setting and trying to get a sense of what the patient is actually like, activity level, how sick are they, what are their goals of care. You have to watch out again for early mobilization. So right when that fracture is the most vulnerable is right when we want these patients to be using the joint. So I think using lots of great internal fixation supports with that rafting screw, recognizing where the good bone is in the pelvis is really important. I think that map of the bone density in the anterior column and utilizing, those quadrilateral plates to push and buttress out. I think those were great techniques. I'm going to take those home with me. And don't be a nihilist, Lebowski. We want to have some optimism of our trade and our patients here. And then again, but that being said, you got to recognize the ones that are going to be prone to failure. Which ones are the ones that are going to get that 30 to 50% early failure rate? And I think that was a really nice review of the literature predicting that. And I think that has borne out in real clinical practice as the years have gone by. And I think these technical pearls of stabilizing the columns, getting that engagement so you can press in and wedge against those two columns, and then under reaming by one. That's another way to get good engagement of the cup, is to not do the line-to-line ream that you might expect from the manufacturer's recommendations, because the bone is usually soft and it's already resorbing at that time. So again, this is a personal plug. I think all three of us are kind of on the traumaplasty spectrum here. We all do trauma, but it's becoming recognized that especially for hip replacements, it's a good skill set to have for the traumatologist. Hopefully you guys are getting good exposure to that in your residencies, maybe even in your fellowship training. There's even the OTA is actually going to be hosting a course on that in Las Vegas in November, recognizing the importance of the role of knowing how to do a total hip, because I think having the fracture perspective and then an arthroplasty perspective really gives you a lot of insight and a lot more comfort for some of these patients and indications. So again, I want to thank everybody for their time and the extra 5 minutes that you've all given us to hang with us today. Please feel free to reach out to any of us. We're all AO faculty. And then this is also going to be available to you as a recording shortly and on YouTube. So thank you again, and thanks to the AO staff for the excellent technical support.